So next we have our early adopter pediatrician panel. And these are wonderful pediatricians who have been screening for ACEs and instituting trauma-informed care in their practices in a wide variety of communities, practice types, and they're here to share with us a lot of the collective wisdom that they have from years of doing this work. So I'd like to introduce the panelists. Dr. Deirdre Bernard-Pearl is general pediatrician and medical director of the pediatric and adolescent campuses of Santa Rosa Community Health, where she implemented ACEs screening 6 years ago. We also have Dr. Paula Spinas, who is a pediatrician with Kaiser Permanente in Hayward. In the last 4 years, he has led the local committee that implemented ACEs screening in pediatric primary care settings. And he also serves as the chief of health education and is the medical director of Kaiser Permanente and Primary School Partnership in Hayward. Dr. Elizabeth Grady, or Beth Grady, is a general pediatrician in the South San Francisco Clinic, a community clinic at San Mateo Medical Center. Dr. Grady began screening for ACEs in 2015 and has led a team from San Mateo County Health and the Center for Care Innovation's Resilient Beginnings Collaborative starting in 2018. Dr. Oniyin Omatosho is a community pediatrician and the pediatric medical director at Lifelong Medical Care, a federally qualified health center based in the East Bay, where he has been leading implementation of trauma-informed care. And Dr. Miriam Rue is the medical director at UBCP Bancroft Pediatrics in San Leandro, which has been implementing trauma-informed care and Pearl screening since the fall of 2019. Dr. Rue is a member of ASHU, or Addressing Social Health and Early Childhood Wellness, a Quality Improvement Learning Collaborative, and the ACEs Aware Communications Think Tank with the American Academy of Pediatrics, California, Chapter 1. Thank you so much to all of you for being here this morning. And I would like to start our first question we have here today. And this is for all of you. I would like to ask you just to describe your practice setting to us, when you started ACEs screening and trauma-informed care implementation. And just a few quick thoughts. And let's start with Dr. Bernard-Pearl.
Hi, thanks so much, Dr. Chung. It's a pleasure to be here, and I've learned so much from this conference already. Thank you. I work in Santa Rosa Community Health, which is an FQHC. We've been doing universal ACEs screening in pediatric primary care for 7 years now. We started with some grants from Healthy Tomorrows and the Kaiser Community Benefit.
Wonderful. Dr. Beth Grady.
Hi. At South San Francisco Clinic, we are a small community clinic in the San Mateo Medical Center system. And we have 1.5 full-time equivalent pediatric providers. We've been screening for ACEs in some form for about 5 years. We started by asking some questions from the AAP Trauma Toolbox for primary care, adding them to our Staying Healthy assessment. And since September of 2019, so a little over a year ago, we have been using the Pearls.
Wonderful, thank you. Dr. Paula Spinas.
Hi, can you hear me?
Yes.
Perfect. My name is Paula Spinas. I'm so happy to be here. I've learned a lot listening to everyone. So thank you so much for having me. And I feel very privileged to be able to listen and learn. My name is Paula Spinas. I work as a general pediatrician at Kaiser. We are, of course, a large integrated health system. I represent about 4 medical centers, 4 pediatric clinics, about 60 pediatricians. We've been probably screening for the past 3 or 4 years. We started with the 3-year-olds, and our approach is a little bit different in that we're screening ages 1 to 5 yearly for all well checks during those ages.
Wonderful. Thank you so much, Dr. Spinas. Dr. Omatosho.
Good morning, and thanks for having us here today. I'm Dr. Omatosho with Lifelong Medical Care, another FKC in the Bay Area. The last 2 years, we've been doing a lot of work on trauma-informed care and in the workplace. We're a mix of both pediatric only and also family practice clinics. And we were kind of working towards a pilot on ACEs kind of right before the pandemic started. So we haven't actually started implementation.
Wonderful. Thank you, Dr. Omotosho. And Dr. Miriam Rue.
Hi there. Thanks so much for having me. I've also really enjoyed presentations so far. So Bancroft Pediatric Medical Group started about 80 years ago. And then we were acquired by UBCP, which is UCSF Benioff Children's Physicians, about 4 years ago. So we are a private practice, but we're owned by a larger organization, but we still operate much like a private practice in the community. We started screening and although we're a private practice, we reflect kind of the population that we live in. And so we take about 75% of our patients are actually publicly insured, with a lot of them coming from immigrant families. And we started screening last year, as you mentioned.
Wonderful. Thank you so much. Next question, workflows. Can you describe your clinic's workflows for patient engagement? Like, how do you tell them about screening? Okay, and when do you actually give them the screening instrument? Talk about the documentation and, if you will, adaptations to telehealth. And I would like to start here with Dr. Miriam Rue.
Okay, great, thanks. So as I mentioned previously, we are a private practice. We do not have social work, behavioral health, mental health in our offices. And so for us, it was a lot about kind of getting a workflow that was fairly efficient and that would flow quickly in our office. We did have, we worked with Dana Long and the Find Connect program, and we did this as a pilot with our Alameda Alliance for Health patients. And so those are patients with managed Medi-Cal. So, and we followed this workflow quite a bit. We actually worked a lot with Dr. Long on it. So when our patients come in, they get the Pearl screen from our front desk. There is a script in the front telling them why we are doing the screen. They then will go to their room, fill out the patient screen. The parents will fill it out for kids who are 0 to 11. For the teens, we will, when they come to get their hearing and vision done, then that's when they will get the screen so that they can answer it on their own. Because, yeah, and then the medical assistants will go ahead and do the scoring. They will put that in the EMR, and then the provider will hopefully get the results prior to going into the room. I'm not going to talk about what we do in the room, as you're going to get that afterwards. And you had a great presentation from Dr. Jung and Jen Leland about that. Once that's done, there were a lot of questions coming through about billing and documentation. So in terms of billing, we use the G code, and it's for if it's 4 or more ACEs, then we use one code. And it's just the ACEs, as Dr. Long mentioned, it's not the social determinants of health. And then if it's less than 4, then we'll use the other G code. And then if it is positive, and for us, that's if they have 1 or more, then we'll go ahead and put stress in their problem list, and it will associate it that way. And if they have nothing, then we'll just associate it with their encounter for well-child visit. For us, what was really important was that we normalize the process in hopes of being super efficient. We started at first with just the younger ages, or with the ages where we didn't have to do other things. So we started with 3 and 12 because there were no vaccines happening at the time. And there were also no other screenings that we were doing at the time. And because it operates much like a lot of our other screenings, like our ASQ and our PHQ, we were able to increase the numbers of screens. So now we're screening pretty much all of our patients who have Medi-Cal every year. So in terms of telehealth, we did some adaptations. And so in the office, they get it all on paper and their families are doing it. In terms of telehealth, we're having the medical assistants actually read the questions to them. We do it de-identified. And so they read the questions and they just instruct them to kind of count on their fingers how many are positive, and then they just give us a number. And then the medical assistants will just put that number into the chart. And then we will talk about it more generally for the families because we don't necessarily know who's in the room and how comfortable they feel. So we'll talk about stress in general and how that really impacts health. And then we'll offer resources to everybody. So we have something built into our EPIC documentation that basically pulls up all the resources. For families that do, are asking for resources, or that we know would like some more resources, we are using the Find Connect, which you'll hear about later, which is a fantastic program. It really gives them the resources where they are at. We also use Help Me Grow, we were using them prior to doing the Pearl, so that was very easy to do. And for the pediatricians, we also love the child and adolescent psychiatry portal. So we're able to call them and, talk to them about some of our kids with some mental health issues.
Wonderful. Thank you so much, Dr. Rue. Dr. Beth Grady, can you please share with us your clinic's workflows around ACEs screening?
Sure. So at the South San Francisco Clinic, as I mentioned, for about a year, we have been conducting a pilot of using the Pearl screen. We heard about the Pearls through participating in the Resilient Beginnings Collaborative. And also as part of that collaborative, our clinic had one clinic-wide training on trauma-informed care. So when we heard about the Pearls, we basically wanted to do our best to replicate what Dr. Long was doing in her clinic, but we didn't have health navigators or on-site community workers or social workers. So we were able to work out a collaboration with our Family Health Services Sector home visiting program, where a community worker from that program would come to our clinic 2 days a week to administer the Pearls. We went through a bunch of different kind of options for workflow, but what seemed to work best was for the community worker to meet with the families in the exam room after the medical assistant had done her rooming procedures. The community worker would present a cover letter explaining the reason we're screening, that we're screening everybody, and that answering any of the questions was completely optional. And she actually would generally ask the questions verbally. There was a question in the chat about how you accommodate parents who are non-readers, and that was one way that we did that. That was actually kind of our default, and if patients preferred, they could complete it, in writing. After the screen was completed, the community worker would score it. For all families, she would provide a packet with information about ACEs and toxic stress and resilience strategies. And then she would enter the score in the medical record. We also created a template so that both the score as well as the appropriate CPT code would be entered. We found that the community worker process took about 5 minutes, which seems like a lot out of a 15-minute visit, but we didn't find, because we weren't doing this every single patient, we didn't find that it impacted our flow too much. And I actually found as a provider that it saved me time, because when I went to discuss the impact of toxic stress with the family, I wasn't starting from square one. So after a couple of months of doing that, the community workers were able to train our medical assistants to do the Pearls. And then we were able to go to doing it every day, or 5 days a week. And we added teens. We had originally been screening just 0 to 11 well-child checks. When we went to mostly virtual visits, or a lot of virtual visits, we initially had the community workers calling the patients and asking the questions, and it actually worked really well. Unfortunately, there were more demands on community workers with the pandemic, and so we ended up going to just having the medical assistants ask the questions, as Dr. Rue was doing, on the phone or virtually. And then the community workers were available for social determinants of health resources and referrals to home visiting. I didn't mention that one of the things what the community workers did for families with positive screens was to offer a referral to our home visiting programs. And we found that some of the families were actually already engaged, but for those who weren't, the rate of engagement with this method of referral to home visiting was actually about twice what it had been under our usual, standard of care. So it did really seem like it was making a difference. One of the best things that we did with this whole process was to create a way to communicate, for the pediatric provider to communicate with the community worker and also with our mental health therapists directly from the medical EMR in the exam room. And this was something that I pushed for. Some of the non-provider, the family health services and mental health team members didn't immediately realize how crucial this was until they actually came and, saw what was going on in the clinic. But the surprising thing about it, we started to do it to improve care, but I found that it actually really decreased my secondary trauma. Just to know for sure in the moment that my referral had been received, that someone else was also going to be helping the family with trauma, just really made it a lot easier.
Wonderful. Thank you so much, Dr. Grady. Dr. Spinas, can you please tell us how you screen for ACEs in the Kaiser environment? I'm sorry, I wasn't sure if I was unmuted. Thank you so much, Dr. Grady. Dr. Spinas, if you could share with us how you screen and your workflows for screening in Kaiser.
Can you hear me okay now?
Yes.
Perfect. So, in terms of the details of actual screening, I think everyone has got a bit of an iteration of each one, in that, it sounds like we all hand out the questionnaire, the receptionists hand out the questionnaire, the medical assistants receive the questionnaire from the families. They then process it. Our doctors do the documentation of it, and per the workflow, they respond to both the scores and have a discussion with the families and refer to resources. In terms of the different parts of the question, I just want to add a couple of thoughts. I think that in terms of patient engagement, I think it's our job to, of course, always create a safe and welcoming environment in kind of a culture responsive way. We want to normalize screening as much as possible, and you've heard that before from the other speakers. And I think that starts at the very moment that the patients hit the clinic exam waiting room, and that includes signage, but also the verbiage and scripting that's coming from your receptionist. I think the staff need to be trained up, both in terms of the philosophy and the science behind ACEs, so they not only have the scripting as tools in their hand, but they understand the reasons why behind that. And I think that helps, again, normalize that process, because I feel like families are coming to the doctors for a very particular reason. And we want to make sure that the families understand that, this content, while it may be new or newly packaged for them, that's indeed aligned with what they're coming to the doctor for. The other way that we engage with the patients around this, I think maybe a little bit different from other clinics, is that in our screening questionnaire, we added an open-ended resilience question. I think the wording is, what are your child's strengths? And I think that that helps kind of center our conversation as physicians. It's not documented anywhere, but what our physicians tell us is that that's a very helpful way to have a strengths-based conversation with the family. Because even if the screening is negative, and for young children, most of the time it'll be negative, it's just a nice way to kind of cement those skills for the families. And also, again, normalize the conversation about resilience, because in the case of future stress, you're kind of already building up the child's resilience. So we find that it's a great way to engage the families in terms of content. In terms of the workflows, the notes around the workflows that I wanted to emphasize is that, for us as a large integrated system, we really want to take a systems approach to this. We really want to make sure that the workflows that we institute are not only integrated easily into normal clinic operations, but also can be scaled throughout our organization. Because we don't want to create a perfect little island. We're going to create something that's going to be able to be used, at least generically, at other Kaisers and other sites. So you have to really make sure that when you develop a workflow or adapt a workflow that's put in front of you, you have to make sure that you've not only taken the perspectives of the families, but also the staff and receptionists and the doctors themselves. The nice thing about this work is that they us as healthcare professionals, we're already knee deep in this work. We already take care of this content every single day. we were surprised to find that in the questionnaires that we use already in our well-check questionnaires, there was an open-ended question, at least within Kaiser: has your child experienced any stressful events in the past year? That is already kind of tapping into this work without calling it ACEs. And I feel like when providers started taking on screening, they were like, wow, this really, I noticed, X, Y, Z about my families, but I just never thought about it in terms of ACEs, in terms of the effects it can on their health. Doctors who are present within their exam rooms, they're already having these hard conversations. I think that's just kind of bolsters those skills. The other great thing about Kaiser is that we are integrated. And so with our workflows, we're able to involve psych, and we actually are blessed to have a BMS provider embedded in our clinic, as long as with a medical social worker. So again, we're trying to leverage all the resources we have at hand and use a team approach to addressing ACEs and trauma when needed. The other thing we did 4 years ago was partner with Help Me Grow, and I think Help Me Grow is well suited to help clinics like ours handle these issues and help families get some guidance and navigation. The last part is about documentation, and the only cheat code that I would say is that the vast majority of time ACEs, the score is going to be negative. We should be talking about stress and resilience every single day, essentially. But for my note, we use Epic. My smart phrases already have the ACE score of 0 already embedded in it, and I go ahead and change it for the 15-20% of the time that I need to change it. So I think that for me, what brings me joy is like getting out of the clinic in a timely fashion and trying to be efficient about our processes. Not only helps me adopt it, do it as a doctor, but I think will help clinicians and staff adopt this content. Thanks.
Wonderful. Thank you so much, Dr. Sunis, and thank you for all the great pearls and tips about clinical workflow. Our next question is, how do we use ACEs screening and scores in clinical assessment and treatment planning? Or that is, what do you actually do with a positive screen or a high ACEs score? Like, how does this influence your triage and your referral decisions? And what are your go-to resources? I'd like to start by asking Dr. Bernard Pearl to take this question.
Thank you, Dr. Jen. The first thing I would say is that I use the ACEs aware algorithm that's being shared now as a way to stratify. But I just want to emphasize that not everyone with high ACEs wants or needs counseling. So as was demonstrated so beautifully in the role play, services can be offered, but not everybody is really ready at the time that we think maybe they would benefit. The other thing I wanted to say is many times people who have high ACEs have already dealt with them, had counseling, found ways to deal with it, group support, different kinds of things. And so I always try to remember to ask if they've had a chance to address these ACEs in the past, or if they've considered getting help. So kind of a motivational interviewing sort of strategy. Some other key things that I found really useful is what I'm sharing here. So the next one is asking how they feel their ACEs may be affecting them now. And this comes up, sometimes people say, well, this was a long time ago. We also screen parents, and often for them, it's kind of ancient history for them. Not always, but often it is. And so having them reflect on how it may be affecting them now. And of course, this is many strategies and many questions, and I don't ask all of them in every encounter, but these are some of my most useful ones that I found over the years. Definitely a moment to educate around how high ACEs can lead to health problems. And this is really new information for a lot of people. It's kind of like connecting the dots. Excuse me. So that, that may be why I've had trouble in school, or my child's having trouble learning, or, having pretty severe asthma, and kind of connecting those dots, that stress and toxic stress can play a role. The next point I wanted to make is that when we think about making a referral for high ACEs, it's just kind of different than how I see more typical medical referrals. So the idea of shared decision making is really important. And I think that was also beautifully demonstrated in the role play. Next point is that letting people know that many people who have experienced ACEs do find that counseling can be really helpful. Doing other sorts of practices can be helpful, whether it's dance or mindfulness or yoga or singing, that all of these kinds of expressive activities, time in nature, of course, can be very helpful and healing. And then specifically, letting them know what's available, you know, as far as right here in the community, especially if you have anything in the clinic, letting them know what they have. And I find that many times they don't already know. So I'll just say something like, well, did you know that right here in the clinic, we have a child and family counselor, and if that service is available to you. So that's a nice way to introduce it sometimes. So as far as my top go-tos, the in-house counseling, I would say, we do have a resource for parenting classes in the community that are free if you qualify for that. And then another resource I wanted to mention is that for the younger children, if you haven't already had a chance to look at the Sesame Street and community videos, they're really well done. They're short, they have English ones, Spanish ones for different types of traumatic experiences and healing. So I'll stop there.
Wonderful. Thanks so much, Dr. Bernard Pearl. Next, we have Dr. Beth Grady. How do you use these ACE scores in your clinical assessment and decision making?
So a lot of what I was going to say, Dr. Bernard Pearl has said already. So I would just say, echo that. But just to emphasize, and this has also been mentioned, that when I talk with other providers who aren't yet screening for ACEs, the biggest concern that I hear is, what am I going to do with the positive score? And this is understandable, as the slide is highlighting. As healthcare providers, we're sort of trained to find and fix, and we have certain ideas of what fixing entails that don't really apply. As we've heard eloquently throughout this presentation, one of the main ways that trauma harms is by interfering with the normal protective physiologic response that happens when one person feels heard and valued by another person. And so framing a patient or family's experience of trauma as important and acceptable to talk with your healthcare provider about is actually doing something, whether or not they decide to even disclose their trauma at that particular time. So in terms of, what do I do? Like Dr. Bernard Pearl, I express empathy. I'll say, I'm sorry that you had to go through that. I'll invite reflection, ask, how do you feel your child's experience or your experience is affecting you now or has affected you? I will give education around the ACEs science of how high ACEs impact the development of an individual's threat response and how certain activities can promote healing, specifically activities, that has been mentioned, things like exercise, time in nature, creative activities, music and dance, particularly traditional music and dance, and ideally in normal times done in a community with other people. I will also ask the family to identify the child's strengths, both as a segue to highlight how developing talents is also a way of mitigating the impact of toxic stress. I'll ask if the child has an opportunity to, to develop their talents to do the things that they're good at, and if not, what would need to happen for that. In the rare instances where the family is unable to identify a child's strength, that is a big red flag, and I will definitely want to be spending more time with that family. I do also offer referral to our mental health counselors, but at the same time acknowledge that talk therapy is not for everybody, and that there are other ways you can, other types of therapy, as has been mentioned. And lastly, and I hope you have this on the slide, if not now, later, pretty much the single most useful thing I found in clinic is the book Once I Was Very, Very Scared by Chandra Ghoshipin. This is a beautiful picture storybook that talks about the different types of trauma that children can experience, common reactions to trauma, and things that can help, like all the stuff that we've mentioned. This is available free online at their website. We've also gotten some copies in the clinic, and it's really helpful for that doorknob comment where at the end of the 15-minute visit, when you have like 6 people waiting, the family discloses just this incredibly significant trauma. I'll say, that's very important. Here's a book I'd like you to take a look at, and let's schedule a time that we can talk about it soon. And I've actually had a lot of patients, say that they found the book to be very helpful to them.
Wonderful. These are great tips out in the real world of practice. So thank you so much for sharing those. Our next question has to do with supporting staff through this transition to trauma-informed care. It's not easy work. How do you address the vicarious trauma in your staff? And how do you prevent burnout? And how do you actually prepare your organization for what Dr. Epstein had described, like changes everything? So we are going to start with Dr. Ni Omatosho.
Thank you, Dr. Jane. Yes, our organization actually started with a grant about 2 years ago through Center for Ehr Integration and Genentech on trauma-informed care. And we started with kind of trauma transform, providing an introductory training for all our staff at our pediatric sites on what trauma-informed care looks like, what ACEs was. And the goal was to help kind of build an environment where we could screen and pilot ACE screening as well. So initially we did that. We talked about the science of it with our staff. We talked about trauma-informed care and how it's what we're doing already, but just ways to kind of slightly alter what we're doing in a way to have more impact for our families. And so we started along with this and thought, we're excited. This is something that is very important for us to do as an organization. And started talking about ACE screening, looking at the pros screen, and then we started having lots of questions, which a lot of pediatricians and also other staff will have that. We don't have enough time for this. How we handle, opening up the can of worms. How we have enough time, or who do we refer to? Do we have resources? And we kind of had to take a step back at that point and realize that staff was really trying to tell us that they weren't quite ready. To do this, and that was kind of a light bulb moment when we realized that to do this work of, it was very important that not just our patients feel safe, but we have to make sure our staff are taken care of and feel safe, and that will allow us to be able to provide really trauma-informed care to our patients when they feel safe in our office environment. And that was where we decided to actually pivot a bit and kind of focus on staff wellness. So we decided to kind of start to practice, those trauma-informed care doctrine we've been talking about and trying to reflect it and model it for our staff. And so we started focusing on how do we incorporate this into our clinic practice, organizational culture. And so we kind of changed how we do our staff meetings, for instance, making sure we're doing it in a trauma-informed way, engaging our staff to have them actively participate in our meetings. We started making sure we talk more about staff wellness in terms of things we could do to help release stress, like Dr. Benelong showed with the ACEs Aware Stress Busters. We started including that as all of our meetings. We did a little segment into asking staff exactly what their jobs were and their roles and how to explain to patients what their roles were. We even made badges that explain I'm a community health worker, or I'm a pediatrician, or I'm a nurse versus a medical assistant, and created actually a video in our waiting room that helped to explain to families coming in actually what each member of the team was doing towards taking care of them in their medical health. And so we've been doing this now for almost 2 years, and kind of getting closer to doing the screening. But, depending on your practice and the staff and the feedback you get from them, it helps you figure out where exactly you are and where you need to go and what you need, which is going to be unique to your own clinic setting. A good example of this is with COVID pandemic, we closed our clinics and had to do everything telehealth. And then we're discussing how do we reopen for in-person visits. And we started with very skeletal service at first, and we're talking about how do we expand this so we can meet the needs that patients have for watch-out checks, for vaccines. And we had talked to our staff about, infection control and how you limit exposures and how we're going to have screening calls done, temperature checks, check symptoms of patients, have only one parent coming for the visits and all that. And realized that our staff was really very anxious about it, not just about their own health and their families, but also about exposing our patients to COVID as well. And so we decided to use our next staff meeting to just focus on that issue and talk about stress and how we react to stress. How do we manage and cope with stress, and also about the pandemic itself and how it's impacted our lives, and our families. And also, in spite of it, what are the things we're grateful for, being able to actually see positive out of this? For some people, it could be spending more time with family. For some people, it could be still having good health and having a job in spite of everything going on. I kind of talked about all those things and how we manage and handle stress. We even added a game, like a game with gift cards about infection control measures, and kind of did that just to help staff understand that we understood that they were having a lot of anxiety and stress about this pandemic. And we're not ignoring it, but we're acknowledging it and seeing how we could best do this, knowing that they all want to provide great care for our patients and at the same time stay safe. And so that was just one example of how, by modeling trauma-informed care, our staff was more engaged, more aware about what we're trying to do in a way. And going forward, that helped us a lot so that they were able to find actually an in-person clinic. We've expanded our in-person clinic since then, and there's been no hesitation from our staff to take on more shifts, to do this, because they know that we've actually acknowledged their fears, even if we can't make the fears go away. But they know we're actively listening to them. Thank you.
Thank you, Dr. Omotoso. I really like a lot of what you had to say about listening and really listening to your staff and seeing where they're at and taking the pulse within your organization, just how important that is, and that there isn't a one-size-fits-all solution for everybody. And sometimes it's worth taking a step back and reconsidering what's your organization's readiness for this step and what do we need to do to build trauma-informed foundations throughout the organization before moving forward. Also liked what you had to say about practicing what we preach, basically, especially in how we treat our staff. A lot of what we say about trauma-informed care with our patients very much sounds like this is how you're treating your staff as well. And walking them through transformations around trauma-informed care as well as during this time of COVID. So thank you so much. Dr. Rue, I would also invite you to speak to how have you been supporting your staff through this transition to trauma-informed care, and how are you addressing vicarious trauma and preventing burnout? Dr. Rue?
Thanks so much. We were an organization that was much like Ken described earlier, kind of trauma inducing. So when we started the screening a year ago, it was, we did have a session to talk about why we were doing the screening. But it was, here's the screening, we're going to implement it, go right ahead, and we're going to just do it the same way we did it, right? So it was very kind of a top-down approach. And our staff is fantastic. And so they were able to implement it fairly quickly, but we realized that this is not how we wanted to show up at work. And so we did take that step back. And so we started having we created a gratitude board. We created a shout out board so that we could all recognize all the work that we're doing with each other. We actually created a vision board, and we used Bancroft for prompts. So, the staff together decided, we wanted to be balanced. We wanted to be advocates. We wanted to nurture. I won't go through all of those. We had theme days. So we had Motivation Mondays where we would bring a motivational quote and talk about that. We had Wellness Wednesdays. We cooked together. Fun Fridays where we'd all dress up. Things that, that a lot of offices often do, but we were more intentional about those things. But what really pushed us into kind of being more of a trauma-informed practice was the pandemic, honestly, because we were then experiencing a real collective trauma, not just for our patients, but for us, our staff, the world. And so one thing that we did was we actually brought in some daily group huddles. And we found that this was really important for us. At that time, we would, a lot of the beginning was communicating a lot of the changes that were happening. And then we found that it was actually a really great time to collaborate and really listen to what the staff was saying and to get ideas from them as well. And also because they have a much better pulse on what the patients are bringing to the visit when they walk in the door. And so we found that when we really listen to what they had to say, that we could really improve our practices. During the huddles, we did the same thing as Dr. Omotoshu. We brought in a lot of those stress busters into our huddles, and we talk about like, how is everybody feeling today? What are you thinking about what's going on? How is that impacting you? How is that impacting your families? How is it impacting how you're showing up at work? We brought in some mindfulness sessions. So we did some of that belly breathing together. We actually did a mindful masking thing together. So we talked about our masks and why it was challenging to keep them on all day and why it was important and ways to kind of help us, keep those masks on all day. We talked a lot about nutrition and sleep, and we shared with each other, like, what are you doing when you can't sleep? What are you doing when, you're having a hard time at home? And then with the increase in the racially motivated violence over the summer, we actually took some time and had our staff members talk about themselves and kind of how they grew up, their cultural background, and we just gave everybody 5 to 10 minutes at the beginning of each huddle to talk about that. And it was great because I've been in this practice for 19 years, and to really hear them talk about themselves. It was interesting because even I was a little nervous because we don't usually talk about our backgrounds. But then we took that and we talked about how we are all similar and how we are different, and things like that. And I think all this work, really, I realized how fantastic doing this work was with the fires. Our office got pretty smoky. And so we, together we decided, like, we can't work here because there's a lot of smoke in our office. And so we were able, as a staff with very little drama, we were able to move everybody at home. We could still do all the telehealth visits. We did that within an hour. Our staff was working it from, all of us were working from home, and we were able to take care of our patients with very little drama. So this work is great.
Wow, that's very impressive. Thank you, both of you, for sharing those wise pearls about how you address like big changes, fast changes, but to bring your staff along in a trauma-informed way. Next question has to do with how we use our electronic health records in this work. How does screening integrate into our EHRs? Can you leverage them for data collection, quality improvement? And so with this, I'd like to turn to Dr. Polispinas.
Can you hear me okay?
Yes.
So I think it's a great question. And a couple of notes around EHR integration, data collection, and QI projects. Certainly, with the advent of electronic medical record usage and data, it opens up a world of possibilities. And I feel like, especially with first in terms of scale, there are things you can do at multiple different scales. We've done stuff where we're simply hand counting, like the staff is hand counting. We'll create a little capacity for them to do it. We've done stuff where we'll have a research assistant do QI level data for us. And then we've actually done stuff where we've actually asked for grants and gotten research grants to get that kind of publishable research level data. So again, there's a world of possibilities that open up to you. But in terms of the EHR integration, the first thing I want to say is that, for our strategy is to document, like you heard before, the screening for adverse child experiences, edit that diagnosis on the problem list with a de-identified score. And, beyond the data, I think that what allows you to do is really kind of integrate all this content and this work into your day-to-day practice, such that if you have an asthmatic that's non-compliant and you're digging through the chart trying to figure out why, and you see that they indeed have an ACE score of 1 or 2, for me at least, that makes me pause. And it really makes me harken back to this work and grounds me in the trauma-informed lens, which I think is helpful when approaching patients, especially in this situation. It gets me to ask not, why are you like this, but, what is it about your history that affects your current compliance issues, for example. For me, I like that because I feel like we're building a system that pings you to build better relationships with your families. A lot of people complain about the system, but quite frankly, I feel like in this way, we can have a positive effect on the systems. And if we have a system that makes us be more present in the room or present with our patients, then I think we're much better for it. In terms of QI projects, we started with a QI project around just straight up acceptability and feasibility. But we've looked at characteristics of the people who get screened, characteristics of the people in terms of socio-demographic data, in terms of comparing that across the spectrum of ACE scores. We've looked at the association of positive scores and certain diagnoses, association of scores and healthcare utilization. So you can ask all these interesting questions around once that's nicely embedded, represented in your system. The really kind of cool stuff is even if you don't get grants to research this, I feel like getting that QI level data is much different than looking at a study that examines the same, that asks the same question. Because instead of reading a study of some other geographic data, similar geographic area, there's great studies happening all over the place and stuff like that. But there's a big difference between that and actually looking at the same questions and your own patient population. Because if you find the needles, then you start asking, so what are the levers we can pull around trauma and obesity and pediatric obesity, trauma and ER utilization within your own system. And I think it's very helpful actually in terms of advocating for this work, because if you have that QI level data and with those data sets in front of you, you actually go to your leaders and say, this is not an abstract, this is actually happening within our population. So I would put care into being able to put those questions and those measures in front of the work that you do, because I think that helps you evolve the work and helps you advocate for the work within your own systems. Thank you.
Wonderful. Thank you so much, Dr. Spinas, for those helpful tips. Last question for the panel, and this is for each one of you in turn. I'll call you in turn. What are some general tips or lessons learned for successful implementation? This is just kind of like your big takeaway that you want people to take away from this. And we'll start with you, Dr. Bernard.
Thanks, Dr. Jung. I have three points. First is train all staff, not only the medical providers. See it as a culture change. We really need everyone on board to make this successful and helpful to our patients. Number two, create and cultivate an environment that's non-judgmental. This is what creates the essential psychological safety to do this work well. And number three, the conversation itself, responding to someone's ACEs in that empathic way, that conversation itself can be healing and part of the actual treatment and help for the patient.
Wonderful. Thank you so much, Dr. Bernard Pearl. Dr. Beth Grady?
So everything Dr. Bernard Pearl said, and I would add that it does get easier to do this work. I guess there was a question about how long it took to get comfortable with doing this. And I would just like to point out that as pediatric providers, we have been hearing about trauma and seeing its impact as long as we've been in practice. And I found that just having the language to talk about it with families, as well as resources and information to share, helped even from the minute I started doing this. But you do get more comfortable talking about ACEs science, and especially when, things like constipation or, other things come up, it's really easy to work it in. I wanted to share something that I heard in the ACE.
Dr. Grady, you're muted right now. You can
Oh,
unmute yourself.
So I don't know who to credit this to, but I've used it a lot and told people about it. And it's something called Code Gold. We have Code Red, Code Blue, to communicate sort of securely with our colleagues without freaking our patients out. And Code Gold means I am experiencing secondary trauma right now and I need support. So, pre-COVID, when one of us would say that to another in the clinic, we would, go in a room and hug or something. Now it's just kind of a virtual hug, but still works. And then the other thing that I wanted to point out is, another concern that a lot of people have is that this is going to take so much time. And, it does take a little bit of time, just like doing anything, but there's just a lot of evidence that it's not only is better care, but it actually saves time in the long term and even sometimes in the relatively short term. I definitely recommend I heard someone talk about the California ACEs Academy. All of their webinars have been excellent. There was a really great one a couple weeks ago with Dr. RJ Gillespie, who along with Dr. Bernard Pearl is one of the true pioneers, not just an early adopter in this work. And he had this incredible example of a mom who would, as he put it, routinely show up to well visits with 70 to 80 questions. And just after having this discussion about trauma, it went down to 3. So I haven't seen it at quite that level, but I have definitely seen the same thing.
Wonderful. Thank you so much, Dr. Grady. Dr. Spinas.
Can you hear me okay?
Yes.
Great. So a couple of the just 2 tips that I would say is that everyone's a little bit hesitant and a little bit sometimes even anxious about taking on this work. And I will say that every time that we've asked the questions, I think especially in settings where it's done right, where you have training, education, a very clear workflow with clear steps for everyone to do, that when you actually ask if it's feasible and acceptable for this work to happen, it indeed is. The tune of 95% of respondents for staff, clinicians, patients, they all either find that it's either neutral or they're happy that we're taking on this work. So I know it's a lot, and there's a lot coming at you, even in this very conference, but I want to assure you that if you do it right and maybe perhaps do it slowly, that I think you're going to find it to be very, very successful. The other point that I want to make is that for me, this conversation is not just about ACEs. ACEs is just one domain in which we can explore this work, but it's not the ultimate goal. The ultimate goal for us is total health, where people achieve their optimal health in terms of mental and physical and kind of life goals in terms of those domains of health. But I think that you can't forget about resilience, the strengths of the family, and just being present and a good partner for this family. So ACEs is a focus sometimes and it's a way in, but it's not the only focus that we should be honed in on this work. Thank you.
Wonderful. Thank you so much, Dr. Spinas. Dr. Nii Omatosho.
Thank you. I wanted to say that for us, I think one of the things is good to keep in perspective that, we're the medical home for our patients, and the foundation is having a trusting relationship with our patients, the patient families we're working with. And doing this work kind of continues that, So think of it as this is a further step in the work we're already doing with our patients' families. And like I mentioned earlier, it's very important too that we're making sure our staff are engaged and we're actively listening to them as well, because that's what's going to help us do this work. This is not just the providers, but actually the medical team doing this work. And so it's important to keep that in mind. And then as you go along, like you mentioned, you want to celebrate the successes along the way, because this is hard work. But it's important to also acknowledge, the steps we've taken already at this point.
Wonderful. Thank you so much, Dr. Omatosho. And Dr. Miriam Rue.
So I would like to echo everything that the previous speakers have said. And for me, really, it's, this is kind of why I went into pediatrics, right? To kind of come from a place of wellness and health and strength, and to really help our caregivers, raise resilient and healthy children so they can become resilient and healthy adults. I mean, that's really where pediatrics is at. And I kind of want to actually now take kind of the lessons learned kind of back to all of you guys. You've heard from a bunch of different pediatricians, right? We've all got different practices, but we are all busy pediatricians. And really, if all of us can bring this huge culture change into our offices, then the rest of you definitely can as well. And it's fun to do it, actually. I mean, it feels heavy sometimes, but actually it makes my day go by so much better. And, the other thing that you heard is it really takes a village, right? So, we want to have you guys come into our village, ask lots of questions, come talk to us, join. There's lots of collaboratives going around. So yeah, we'd love to have you join us.
Wonderful. Thank you so much, all of you, for this great wisdom. I've learned a lot working with you and hearing from you today. We do have a couple of minutes, and I want to take a few questions that have come through at various points through the conference today, including just very nitty-gritty questions about screening that I want to address to this group. So one is, what if a parent or a teen refuses to do the ACEs screening? What's been your approach?
I'll go ahead and take it. If they refuse, then it's fine. We do this universally every year. And so if they're not ready to do the screening at the time, then it's totally fine. We can talk about stress and what stress and impact on health and why we are doing this screening. And if they don't want to do it, it's totally fine.
I would just echo Dr. Rue's comment. And one of the things that we learned through the Resilient Beginnings Collaborative, our site visit to the Montefiore Medical Center, who's also a true pioneer, is it's actually incredibly important to stress that it's optional to answer the questions, because part of the definition of trauma is an unpleasant experience over which you had no control. So it's really important that families have control over the process.
Wonderful. Thank you so
And
much.
I'd like to add one more thing. For every screen family through our system, everyone's getting the same tip sheet. We created kind of a streamlined tip sheet with tips and resources. So whether you answer the question or not, you're getting the same information.
That's great. This question came up that I actually want to address to Dr. Bernard Pearl, is with our teens, how we administer ACEs screening to teens in a confidential way. So they don't get in trouble with their parents. If you could take this, please.
Okay, sure. It's a good question, because when we started this work, we were doing the teen visit model where the teen and the parent get roomed together, and then the visit starts, and then we explain part of the visit has to be without the parent. And so we, ask their consent and excuse them and have the confidential portion. But what we were doing was we were giving the screening to the teen right when they were being roomed. So they're being asked to do this very sensitive screen with their parent next to them or looking over their shoulder or in their presence. And when we did our first round of reviewing results, we found, lo and behold, all of our teams had 0 ACE scores. So something's wrong about what we're doing. So we actually flipped it around, tried a different way. We started rooming the teens alone first with the parents' permission, and then bringing them in at the end of the visit instead. And when we did it that way, and the teen was alone in the exam room with this questionnaire, that's when we really found out what was going on with them. So that worked for us.
Wonderful. Thank you so much for that. Moving away from patients, how do you work with colleagues who don't believe in ACEs screening?
I think from my experience with staff as a whole, I think the key thing is really sitting down to figure out what they think about ACEs exactly and what their concerns or questions are about. Because until you actually sit down and listen to their kind of comments or their thoughts on it, you can't really understand and begin to see where you can have a conversation. But I think this is a conversation you're going to have over time to better understand their perspective and explain, what we know from the science and the positive impact intervention can have. But it's all dependent on your relationship, with your colleagues to begin with.
Wonderful. Dr. Bernard Pearl.
I would add to that, you know, not everybody necessarily should be doing this. If they don't, if I have a colleague who doesn't really embrace this model, they probably shouldn't be doing it, right? We're trying not to do any harm. We're trying to make this a healing experience for the patients. And so if they don't understand it, or if they disagree with it, don't believe in it, they really shouldn't be doing it. That's my feeling.
Yes, Dr. Rue.
Totally agree with that as well. But my other point would be that I think a lot of the resistance is because we are trained to fix. And so when we feel like we can't fix the problem, and some of these problems are big, right? Then there's a lot more resistance. So I think that kind of talking to you know, our colleagues and explaining that it's not about fixing the problem, but really just listening, and that a lot of the healing comes from, you know, listening to people's stories and just reflecting back and explaining the science, you know, you get a lot more buy-in. But I think that's where a lot of the resistance does come from.
That's a great point, Dr. Rue.
That's wonderful. And unfortunately, we are at the end of our time for this panel. Thank you so much to all of you. I personally learned a lot from all of you, and I hope our audience has also done the same. So thank you for the work that you're doing, and for the leadership you're providing, and for your wisdom that you shared with us today. At this time, I'd like to invite all of us to take a 15-minute break. And there was a question that came through about waiting room videos, and there are a bunch of great videos out there, and some of them are included in a PDF resource packet that was sent out by email early this morning. And so if you didn't see this email, check your spam folder, because this email has a lot of links to our slide decks, to our speakers' bios, to our program, and to this packet of resources, including some videos, children's books, and community resources, lots of good stuff in there. So dredge your spam folder if you need to, but I promise you it was sent out this morning. With that, a 15-minute break. Please come back by 11:30.